Thank you, Asaid. Unfortunately, I have to pass on Asaid's apologies. He can't be with us tonight. He has since he left my group. He did his MSc with my group. He then went on to Harvard to do some postdoctoral work there, and he's now secured a surgical training rotation in Texas, and he's on call. So I do apologize on Asaid's behalf that he can't be with us. But thankfully, I can hopefully field the questions. That does mean I can't ask myself questions, though. So I'm relying on you as the audience and my fellow chairs to ask me questions. Duca has the first question. 150,000 operations. It should have said in 121,500 patients. So I'm sorry, there must have been a typo on the presentation there.
Yeah, there was. Can I have a question to you, Dominic?
Yeah, of course.
I was obviously disappointed by the fact that in this series the likelihood of being reoperated after limited fasciectomy was similar to after being operated as a dermofasciectomy. Do you have any thoughts about that?
Yeah, I think we must keep in mind confounding by indication. So this is not a randomized study, and each surgeon will have picked the particular operation for the particular patient in front of them. So it may well be that the dermofasciectomy patients had higher risk of recurrence to start with, and that's why dermofasciectomy was selected, and therefore showing they have the same overall risk of reoperation is actually a success of that treatment, and it's a successful choice of treatment by their surgeon.
Yeah, I'm not sure if I agree with you about that. Obviously, there have not been any RCTs comparing limited fasciectomy and dermofasciectomy, but apart from the study by the group of Joe Dias, I think there has not been any study that has shown that there were similar recurrence rates for following limited and dermofasciectomy. There were all cohort studies, and the worst recurrence rate was 9% after dermofasciectomy, 8% in 10 years by the group of Logan. So I wonder, I still don't understand those figures. In my personal experience, I don't see any recurrence under the graft. I do see recurrence as more as proximal and distal to the graft, but I would not look upon that as a recurrence of dermofasciectomy. So
yeah,
that may
and of course,
be the bias that it's.
Yeah, of course we can't pick that out because we can't look at all of these patients' notes. So yeah, you're right then that we can't disentangle true recurrence as you might define it versus reoperation for extension of disease. Absolutely. But you may argue from a patient's perspective that another operation is another operation. Charlie.
Yeah. One of the very interesting things about this is the relatively straight line of recurrence over a long time at a rate of about 2% per year on average, with a 20% recurrence or reoperation rate by 10 years out. And this is distinctly different than Houston's description of recurrences. If they're going to happen, they're going to happen within the first few years. Do you think that's just not enough data for the old reports?
Possibly. I think if we think about the biology, we're as you said, I think, Charlie, in your talk in the first of these sessions, when we're operating, we failed. So this is a chronic systemic disease, and we're treating symptoms of the disease. So we're like cardiologists, doing a bypass or an angioplasty or something. We've kind of failed when we get to surgery, and cardiologist doing an angioplasty, they're not treating the underlying biology of the disease. And
No,
much
they're
the same
treating the
way when,
angiogram.
yeah, well, yeah, they're treating the angiogram. Hopefully they're making the heart a bit better as well. But equally, we're treating the Dupuytrens in the hand and hopefully making the hand a bit better, but we're not solving the biology. And my reading would be that the biology is still there, and it can continue and it can cause recurrence.
And the question is whether doing a procedure results in the disease calming down or just proceeding in a subclinical way until it raises its head. But the good news is it's also consistent with people not needing a second operation over their lifetime, possibly the majority.
Yeah, certainly what we found was that the majority of people did not have a second operation. Yeah. So there's a question from Duca again saying, patients who are treated with DF may have had other modalities before. So did they have a different baseline hazard compared to the other groups? We haven't, and have we done any analysis to take this into account? So use that as a factor in a regression, for example. We haven't done that. What we did for this particular analysis was look at what we considered primary surgeries, and that was first occurrence of surgery within the data set. We actually had 10 years of data running into this, and the reason that we didn't analyze that was there was a big coding change before that. So despite us, as far as we possibly could, we made sure that these patients were that this was their primary operation. So we'd look to make sure that they hadn't had surgery in that previous bit of the data set that we didn't actually use to analyze. So we tried to account for that as much as possible and make sure this is primary surgery. However, as I alluded to in my answer to Paul, I suspect if you choose dermofasciectomy for someone, then you in your head as a surgeon are thinking that their risk of recurrence might be higher than someone who you choose limited fasciectomy or PNF for, and therefore their baseline risk may well be different. I completely agree, and that's the confounding by indication that I was trying to get over before. Bente van der Berg, also from Paul's group, in the Hess study from Dupuytren, it was impossible to know which hand was being operated on. How do we distinguish between second surgery, so on the other hand, and recurrence? We could distinguish, this is a different data set that we used, and we could distinguish the laterality of these operations. It wasn't always recorded for every procedure, so the recurrence data is on a slightly smaller subset of the data compared to the complications reports. But yeah, good question, but hopefully we covered that. And Daniel Ray has a question. Do we know of any study that has evaluated recurrence originating from extension? I don't know of that. Paul or Charlie, have you come across studies that have specifically looked at extension of disease? And I guess this would be in the context mostly of dermofasciectomy.
Well, or someone who's had one finger operated on and then has another finger on the same hand operated on. Yeah, could be after any. And I'm not aware of any study that's looked at that level of granularity.
Yeah, but
well, it's common.
Extension as a source of recurrence is a bit confusing. So recurrence is when at the operated place you get new Dupuytren tissue. That is recurrence, whereas extension is then you have a place that was previously not cleared of Dupuytren tissue, where new Dupuytren tissue develops. So when you take that extension out, then you can get a recurrence in the area where there was an extension, but you can't get an extension of a recurrence.
But the terminology is goofy because
Yeah.
recurrence is recurrent contracture. It's not recurrent Dupuytren disease. We should really use the word remission for Dupuytren disease, which looks active and then after surgery doesn't look active, but we know it is.
Yeah, that's a new term. Good one.
And again, the other thing I would say to that, Paul, with the patient perspective, with my sort of patient's hat on, do they really care whether the recurrence is what we define as recurrence or whether it's extension that causes recurrent contracture?
Right.
Well, for me, that is important because I do dermofasciectomy because I believe that following that procedure, you have a reduced chance to get a recurrence in the difficult area, which is the distal palm and the proximal finger. So for me, that is essential, because if I would get the same recurrence rates doing a skin graft as after limited fasciectomy, I would immediately stop doing lymphosectomy because it's so much more work.
And changes the hand a lot more.
It certainly does.
And
But interestingly enough, if you think about the sensibility after dermofasciectomy that has been tested, and it seems to be that the sensibility in the skin graft is very similar to the sensibility in a situation where this flaps only have been lifted and put back as in a limited fasciectomy.
Okay, I think I think on that note, it's probably time for us to move on to our third free paper presentation, and this is Saif Ansari from St Helens and Knowsley NHS Trust, so a hospital up in East Lancashire in the UK, and presenting their evidence